afternoon, ladies and gentlemen. It's an honor to be here with such senior people in the oncology ecosystem. The topic that we are going to discuss now is the role of doctors beyond medication. The word doctor brings a lot of words in our minds, right from hope, treatment, medicine, dedication, courage, diagnosis, you name them. Sir, I'll start with you, and I would like to ask the question that the most important thing when anybody hears about cancer is how to tell the person. We have already discussed it briefly. I want to understand from you that are there any protocols that the doctors follow, and how to break the news to the patient and family so that there is some kind of hope that remains?
You see, there is no fixed formula for this. Unfortunately, what Dr. Anupam said in the morning, we are not taught about it in the medical college, how to do that. Because this is the most important part, because when the diagnosis is conveyed to the patient, that is the most difficult part. And when the investigations are going on, they have a lot of anxiety, they have a lot of fear, they have a lot of feelings inside that what the report will come. And when the report comes and you have to tell them, it's the most difficult part. Now, 20%, 25% of the family will come first. They will say, don't tell the diagnosis to the patient. Now, I have a different view, because if the patient is very frail or, not educated at all, probably you tell little bit. If the person is educated, you have to tell them a total thing, because if you tell them the truth, their acceptance of treatment, because it's a long treatment, it's not a 1 day or 2 day treatment, is much better. So my job is to tell them. Now, if the disease is early, there is not an issue, because everything is positive. We tell them the results are good. We have the things to treat. Side effects are much less. But the two difficult situations are when the disease is advanced, or you have a tumor where the outcome is very poor, like brain tumors. We have not made any progress. Or it is a recurrent cancer. Those things are difficult areas. So my policy is to tell the patient what we are going to do, what we have in store, but don't discuss the outcome, because that will be a very depressive thing. So call a responsible family member after the discussion is over and tell the truth to that responsible family member, so that there is no, we are on the same page. But to keep hopes positive, you don't tell the patient what is the outcome. Because, even if I know I am not an astrologer, I don't write horoscopes of the patient. If there are some people who say that he will survive for 3 months or 6 months, that may not be true. So those things should be avoided. You should only say that good or bad, but discuss with the family member, not with the patient.
Very, very pertinent points you have raised here. Moving on to Dr. Vishal, I would like to ask you that when you are breaking the news of somebody having cancer, people always have a view in their mind that doctor is the messenger of hope. How do you balance this breaking the news of something which is as severe as cancer and being practical at the same time, giving hope? How do you balance it?
Thank you, Bilquis. I think taking from where Sir spoke very pointed on this particular topic. Today, psycho-oncology is a subject by itself, and breaking the bad news is a special topic which actually in oncology should be adapted into training. It's very, very important to understand, and this breaking the bad news is not a generic topic where we are talking about just opening up and saying that patient ko cancer hai, ye stage hai, or ye diagnosis hai, ye survival hai. It's a little beyond that, to be customized, personalized. Now the previous team spoke about personalization. Even here, based on the socio-economic status, based on the understanding, I think it's very, very important to understand and give right information. Now this has social connotation, emotional, spiritual connotations, psychological connotations, this has legal connotations. And we faced all dimensions of it. I'm sure all the senior oncologists here must have faced all dimensions of it. Like a lot of the times, like sir said, some of them come and say, okay, please don't inform the family, inform the patient about the diagnosis. That has legal implications also if it's an adult. The similar way, the aspect of if the person is completely unaware about the entire thing and based on the psychological status of the person, if he is about to break down. So it's important for us to consider all dimensions of this particular thing, and breaking the bad news or breaking this particular news of cancer. The diagnosis is an important art that has to be taught, and there are techniques. And it's always good to learn this and spend some time with the psycho-oncologist to talk about these topics. We have a separate psycho-oncology department in our chain, but we do spend time with them learning, and that learning teaches us a lot about our mistakes sometimes. They give us perceptions about what the patient felt when we opened up a news in a particular way, which has helped us relearn. And I would like to add one more point here with regarding to hope, and that's a strange thing that I have found. You see, all that a patient in cancer lingers is hope. He strongly holds on to hope, and that's a very important, powerful tool for him. But it's a double-edged weapon. Now, I always feel it's very important that we are living in an era of informed decision. We are not living in an era of empirical medicine where we are going to tell him this is the treatment, this is the outcome, it's an era of informed decisions wherein we give the necessary information to the patient, and based on that, he has to evolve and we have to handhold him in this, and that's again a place where psychological support, psycho-oncological support has to be assessed and given. One single experience of mine which has always been counter to what I had always thought was, we did a small study with a questionnaire. We called it the 21-gram questionnaire. Actually, it was based on a very funny theory of the weight of the soul. So with the psycho-oncology department, we actually did this. And one of the most interesting finding in this, which we found, was the power of negative thinking. I mean, it was very strange for me to see this, that we always talk about the power of positive thinking. Har waqt socho ki acha hone wala hai, sab positive hone wala hai. But this small study that we did showed the power of negative thinking. And I was finding it very strange on why this group of negative people who think negatively are doing so well. So when we analyzed it a little further, what we found was a very strange thing about this group of patients. And all of us must have seen that group of patients who come and say that they are generally unhappy. Like, he's doing well, he's doing very fine, he's living 5 years, but he's still unhappy. He's saying, wo theek nahi hai, ye theek nahi hai, sir, wo bimari wapas aane wala hai, main marne wala hu. Things like all the time negative. And I used to wonder, why is he so negative all the time? He's doing so well. So when we analyze this subset, this is only a small subset. I'm not trying to make a big conclusion, but I'm saying that this particular group had the least expectations and the highest acceptance. And I think, so they were not really negative thinkers in the true aspect of it, but it's a very important thing for us to understand, if you can understand these two terms. What are his expectations, and can he accept the things the way he is? These are two things that can make a large difference in positive and negative thinking. I found extremely positive people who say कि कुछ नहीं होगा, मैं 3 बार pray कर रहा हूँ, सब कुछ हो रहा है, but he succumbs to the disease, correct? Now, positive thinking or negative thinking, like sir said, we are not astrologers, does not lead to a necessary desirable outcome. But what leads to an outcome is the acceptance you have and the expectations that you build up with, which is very integrated, important with the counseling of it.
You see, it is very unfortunate, and many of the people sitting in the audience will vouch for it. The slots in the outpatient department are 10 minutes, 15 minutes, appointment slots. And when the doctor becomes international, the slot becomes 5 minutes or 6 minutes. Now, whenever the patient comes for listening to the diagnosis, I make it a point that I give them, instead of 15 minutes, maybe 30 minutes or more. Because there will be a lot of listening from the patient. I can tell anything to the patient, but the patient will talk more. And the more he or she talks, the more comfortable they will be. So most of the corporate hospitals, I see slots of 5 minutes, 10, patients are sitting outside and you have to hurry because, so that is one thing, you have to listen more, and if you listen more, it is easier to pass on the message.
Very, very valid point, sir. Ma'am, you want to say something?
Yes, I've heard a lot of doctors say that people ask, how long do I have to live? And the question in my mind always comes is, doctor, how much time are you going to give me to talk at that appointment? I can live 50 years after that, but I need to talk to you and get information. And if you say, I'm only talking to you for 3 minutes, and then my assistant will take over, that is communication. It has improved. There's no question. It has improved from, I've been around from 1985. I've listened to patients who come and complain. We've been in the hospitals. It has definitely improved. I think communication skills of doctors is improving because everyone's bashing them about it. But time is of the essence also.
Modern medicine, it is not criticism. I am also, part of it. The modern medicine has become quantitative.
Yes.
It should be qualitative if you want to be good, but it has become quantitative. Quantitative is good because SOPs are there and you have the data, and to run a place it is very, very good. But unless it is qualitative, things will not improve. And there is a lot of pressure on the doctors to be quantitative, but they have to be qualitative if they have to be, if the patient has to understand what they mean.
Thank you so much, sir. My next question is to you, ma'am. And because Indian Cancer Society is such a large organization, and we are fortunate that today, I think there are people listening to us because of you in Canada and US also.
Yes.
We know that Indian Cancer Society has very good reach in rural areas. So I want to understand that organization like yours, how do they help people in rural areas, and what is the message that goes out? What is their expectations in rural areas from the doctors? More than the medication part and treatment part, what do they expect?
Bilquis, I won't pretend that we are well spread out in rural areas. Like most urban-based organizations, our strength is in the cities. But I would like our survivors to please stand up. Can you stand up, please, ICS volunteers?
Can we have a round of applause, please, for all of them? Thank you.
And the reason I've asked them to stand is because many of them have come from Mofussil areas outside of Delhi. People have come from Meerut, people have come from Saharanpur, people have come from various parts of townships outside of Delhi. It's not rural yet, but we're getting there. Yeah? So what are the expectations? I think we need to remember that cancer doesn't either begin or end in a hospital. The people who get it are people like you and me. We happen to live in the city, they happen to live somewhere outside. The expectations are the same. That one difference, they're afraid of doctors. I think the urban population might argue back, and God bless Google, everyone knows a little more about cancer, maybe the wrong things, but they know. So they come with those expectations that the doctor is going to help them. If you see these same women, or you saw them, at the time when they came for treatment, they were pale waifs. They had little confidence that they were going to survive or do more. But today, I'm so proud to tell you that almost everyone, now all of them, are people who have survived cancer and who have gone out to help others. They have not sat at home. They have not sat back and said, I'm cured, so I'm okay. And that is what I find most encouraging.
Thank you so much, Jyotsna ji. Dr. Vishal, my next question is to you, that other than treatment and medication, doctors also have a responsibility of getting research and development forward so that there are better treatments to come. What is the role of doctors that you think in doing research and development, and how they can help in this area so that there are better treatments?
So I think if you look at globally today, the next 10 years will see a major shift in what is called as a clinician scientist or a surgeon scientist approach, which means he will go beyond the confines of his OPD or OT and also be in the lab, also be a part of R&D, and also be a part of innovation. There's globally also the movement of accelerating research and connecting it with innovations through academia and industry collaboration. And I think COVID is a classic example of acceleration. Traditionally, if you look at bench to bedside medicine, it takes about 17 years for something to innovate and come into practice. 17 years. That's what Lancet and some of the best journals publish. However, the movement of bedside to bench medicine is now further catching up. That means clinicians are more involved in innovative research, practice changing habits, and I think it's going to become a mandate in the coming years in curriculums as well as at practice. I think the simplest things that I see what we could have done is, one of those, in our department in head and neck, we have a speech and swallow department. I think quite a small department, negligible department, not much. But that department innovated, and they had a good team that kept working, and I was very happy to see they actually came up with a very important, in head and neck cancers, typically post radiation and all, there's a lot of issues with mucositis and taste. So they came up with the taste clinics. They gathered data over hundreds of patients, created their own taste protocols to ensure that the patient is not only given cancer cure, but he's also enjoying a biryani, which he wanted, which was his target at the end of 3 months. Now for me, that was good innovation. They used research, they used this platform, and they were able to deliver a patient to able to eat a biryani at 3 months using taste protocols, which they then published in the literature, and they're now running a very successful taste clinics, which they are now expanding across India. I think this is going to be important to take bedside to bench medicines and actually create this momentum. And I just add one more point in this, is that the need for funding by ecosystems is important here, whether it's governments, whether it's corporates. Some amount of money has to be kept aside for encouraging research and innovations in each organization.
Yes, ma'am, please.
I just wanted to add that early this year, Indian Cancer Society released an app which we call Rise Against Cancer. And the reason I'm bringing it up right here is because one of the 5 languages that it is available in is Kannada. And Vishal here has contributed to that, so that everyone gets information in simple doses through a person like him in a language that they understand. It's not, they don't have to go and read in English or in Hindi or any other language that they are not familiar with. Please, everyone, make a note of the QR code. Everything is outside or on your tables. Please look at it. This app is in 5 languages, and it gives you information about cancer.
Thank you, ma'am. Hukku sir, we would like to understand from you that as doctors, what role do you play as educators for patients and also for other doctors or healthcare professionals?
You see, education is very important, and there are 3 areas. One is education for medical students. There are 3: surgical oncology, radiation oncology, medical oncology. Surgical oncology and medical oncology department don't exist in medical colleges. Radiotherapy departments or radiation oncology departments are optional. Still, if it is, and they manage cancer in their medical college. Now, even if the department is there, the students are posted for 15 days. So what will they learn? So that is one part which the curriculum makers have to take interest. So they are, told about cancer, they can see cancer, so education comes. The second part is the primary care physicians. Tuberculosis is very common in the country. if a patient with cough goes to a primary care physician, he orders an X-ray, sees a patch, gives anti-tubercular treatment without. So the primary care physician should have at the back of his mind that if he sees a patch in the lung, it can be lung cancer. So after 3 months, when TB doesn't improve because TB was not there, diagnosis comes and lung cancer which is advanced. So for that, of course, there can be a number of things like CME programs, or you go to the IMA meetings or other meetings and with leaflets and other things. So the third is the patient, which is the most important, and they have to be told, because most 70% of the cancers in the country are preventable, because either they are tobacco based or infection based. Infection, I mean the human papilloma virus. So we should tell the patient to change the lifestyle, to nutrition, exercise. If they have symptoms, we should tell them what symptoms are there. They should approach the doctor. And if we make education at these 3 levels, probably we will be able to catch patients in early stages. And very few patients will go to the late stage. And some of the cancers, as I said, the head and neck cancer, the cervical cancer, the breast cancer, which are common in country, they can be caught at early stage. Head and neck cancer is preventable, so we should tell them the cause of infection to avoid that and avoid tobacco. So education is an important factor, but the question is that education doesn't bring in money, so the hospitals don't spend time on education. It is left to the NGOs, and when NGOs do, they are doing their lot, but doctors and the institutions have to spend time.
Thank you so much, sir. My last question to you, ma'am. We want to understand that as an organization, what role does community organizations they play for survivorship, care planning, and the emotional support to the patients?
Leadership is important to doctors as much as it is to patients and families. Dr. Hukku spoke about sleepless nights for doctors or was it, I think, Dr. Sachdev, who spent sleepless nights when the patient was not doing well. Well, I don't know if you'll give me that little bit of time, but I've been thinking about it, and in our old literature, in the Gita, we are talking about Krishna's lecture to Arjun on the battlefield. So what was the battlefield? The battlefield was when Arjun was pointing out that these are all my relatives, they're all part of me. And how can I kill them? I often think of cancer in that way. I'm fighting a cancer, I'm fighting one tumor, but I'm fighting the whole of my body because of that tumor. How far will I go with treatment to allow me to live at the expense of what? My family finances, my family's well-being, all of that is there. So I don't want to get philosophical, but the fact of the matter is that the one way that the patient can turn into a great survivor is by being a successful survivor and by being a joyful survivor. If they're going to be sort of drooping all over the place, forever complaining, ye nahi theek hai, wo nahi theek hai, then I think their family will often feel, was it worth it? Giving up so much for a poor quality of life for this loved one of ours? Or can they be joyful survivors where they bring joy back into the family? I told you about our survivors. One lady said to me the other day that the biggest thing you have given me is respect in my own family. It really made my day. I think that that is what we are aiming for, to return patients, sick people into vibrant, happy, ready to go. And if you're all here in the afternoon, you'll see just how joyful they are because they're going to perform after lunch.
We'll surely enjoy it a lot. I'm very, very
One
sure about it.
last thing.
Yeah, yeah. Yes, ma'am.
I had requested of BW that we do not separate this conference into doctors in the morning and all the NGOs in the afternoon. We create echo chambers. The doctors know each other, they talk to each other, they know what they're talking about. What are they talking to? And when the NGOs come on to talk about what our reality is, we know each other, we support each other. Why should we be talking, come to a conference and talk to each other? We want to talk to the doctors, we want to listen to the doctors, we take home a lot of lessons, and I hope that the doctors take home some lessons from us. Thank you.
Thank you so much, ma'am. We are very short of time. We'll end the conversation here, but the conversation will continue this side. And if there are questions that any of the survivors, patients, or caregivers have, I think our esteemed doctors and Jyotsna ma'am, she'll be happy to answer. Thank you very much. Thank you so much.